Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing you another really fascinating guest today involved in creating a better tomorrow for many people out there. Today, we have the honor of being joined by Dr. Ebere Okereke, who is a highly respected public health physician who specializes in global health security and health system strengthening, and has dedicated her career and won numerous awards for her work in promoting women and underrepresented groups in the area of public health leadership. Dr. Okariki currently serves as a senior advisor in health at the Tony Blair Institute for Global Change, as well as an honorary senior public health advisor at the Africa CDC, associate fellow at Chatham House, and recently also took on the responsibilities as chief executive officer of the Africa Public Health Foundation. She is currently on a break from Public Health England and now the UK Health Security Agency, where she led the UK aid-funded International Health Regulation Strengthening Project, a very interesting technical assistance project that was aimed at sustainably strengthening public health systems. Dr. Okariki is an experienced trainer, coach, mentor, was an honorary senior lecturer at Leeds and Hull-York medical schools. She is a graduate of the University of Nigeria College of Medicine, as well as a fellow of the UK Faculty of Public Health. Her journey in global health started actually at Liverpool School of Tropical Medicine, where she was first introduced to the field of communicable diseases, and where she completed postgraduate work in International Health Consultancy. And after leaving Liverpool for the first time, she joined the public health specialty training program, where she trained across Northern England and became a consultant in communicable disease control. Her interest then took her into emergency preparedness, emerging and re-emerging infections, zoonoses, ultimately leading her to Kenya, where she also worked for the International Rescue Committee. A really fascinating journey she's been on, a lot of interesting topics to discuss. Dr. Ebere Okereke, thank you so much for taking the time to come on the show today.
Thank you for having me. It's a pleasure.
It's great having you. I would love to start off as we typically do by handing you the floor for a little bit to talk about the beginning, a little bit about your development of sort of your early intellectual interest, not just in medicine, but of course public health, tropical medicine. And I was reading this very interesting interview you gave a little while ago about during your time in Liverpool, you ended up in a parasitology lab, and you caught the bug for for all this communicable disease stuff. But take us a little on that early journey.
Okay, so I think it's important to stress that I grew up in Nigeria. I was one of those annoying kids who wanted to be a doctor age 5. So I've always wanted to be a physician, but like everybody in my younger days, I thought I was going to be a brain surgeon. We all thought we were going to be brain surgeons. One day in theatre put paid to that plan. So when I graduated from medical school, at that time, women generally got encouraged into pediatrics or general practice specialties in medicine. They were felt to be more women friendly. And so I assumed I was going to be a pediatrician. I like kids, but I found working on a pediatric ward very, very draining emotionally, because the level of stoicism in a child who's unwell is just heartrending. And so I realized very quickly that wasn't going to be where I would be. So so you just said, oh, well, do general medical training. It prepares you for everything, and then see where it takes me. And move to the other end from children to specializing in elderly care medicine, which I really loved because I like old people, they tell wonderful stories. But I grew up in a family that liked to travel. So as a child, my father was a physician as well. My mother was a school educator. Summer holidays, we drove pretty much most of Nigeria, which is a very large country, and most of West Africa. Over the years, we covered one country after the other. And so I always had the interest in traveling. So right out of medical school, I went as far as I could get at the time, which was to do my house job in Trinidad and Tobago. And I would say that was my first real introduction to what became my area of interest of late. And that was working with, at the time, this was sort of, early 90s, the HIV pandemic, as it was in that stage where we didn't quite yet have ARV available, and it was really devastating communities. But that was sort of, at the back of my mind. It wasn't really, I didn't see myself specializing in working in HIV. Like I said, pediatrics was what I was supposed to be thinking about doing, and then I ended up moving into general medical medicine and elderly care. And it was actually a clinic one afternoon. I'd finished clinic with the consultant. In the UK, consultants are what Americans call attendings. I was a resident, junior resident, and we'd finished the clinic and everybody had gone home. We're finishing off the last patient clinic letters. And he paid me a compliment. He said, really great work. I can see you sitting where I'm sitting in a few years. And I freaked out because I thought, I don't want to be sitting there. So it forced me to try and figure out what I actually wanted to do. I'd been coasting, just, going wherever with the flow. And that was what took me to Liverpool, School of Tropical Medicine, in the first time, because I thought, I'll go and do the diploma in tropical medicine because I liked parasitology in undergraduate medical school. So maybe that will help me figure out where I want to go. And like you said, it was during one of the lectures there, we had a lecture from Professor Lucas, who is now passed, who was a professor of community medicine, as it was called in that day, working with the WHO. And I had one of those eureka moments. I said, that's what I want to do, communicable disease control. And I hounded the poor chap until he explained to me how you train to do what he did. And so I went back to clinical medicine and said, I need to get a strong infectious disease background. And that was, again, when I first got involved in TB as a clinician, but it reinforced my determination to say, I have to move upstream and work on communicable disease control and look at how we prevent these challenges that we were dealing with as clinicians. And so I did. That's how I got into the UK Public Health Training Program, which is an excellent training program because you have 5 years, which includes doing your master's in public health, where you work in a broad spectrum of areas where you can inform and influence public health policy and strategy. So my specialism was communicable disease control, but I trained to be able to work across the whole public health ecosystem. And so that's the journey. I became a consultant in communicable disease control, as we were called back then. And part of communicable disease control was outbreak response. And as a consequence of that, we got involved in emergency preparedness and working with multiple sectors outside the traditional health system to be able to prevent and respond to emergencies. And then from there, but all through this, my passion for TB was, if anything, it expanded, because I always say to people, there is no specialty in health, in any health system, from clinical practice to prevention, that TB can't teach you something. Because this is a disease that's been with humanity for our entire existence, pretty much. And it has an impact on every organ system. So the major determinants of your outcomes for TB is actually outside the health system itself. You're more likely to get it dependent on your social environment, your lived experience, and your nutrition, all those complexities. And every chronic disease in the world, if you have it and you have TB, your outcomes are going to be worse. So I became involved in improving the systems for TB control in the UK, which you would argue TB is not a big issue in the UK. It's not if you look at the total population, but there are pockets of vulnerability in the UK and people who are particularly prone to disease, and they're hidden because the overall stats aren't that high. It's people who don't usually get attention. So if you're a prisoner, if you're a migrant, if you have if you're immunocompromised, so back to the HIV population, even in high-income countries like the UK and North America, you have a higher risk of getting TB and having poor outcomes. So that's kind of how I got into that. Became my focus for public health and communicable disease control, is how do we address these diseases? They might be infectious diseases, first of all, but they're diseases of inequality. And that then moved me more into how do we address inequity? How do we ensure that the right questions are being asked of the health system to develop policies and strategies that help those marginalized societies? And again, that then links me into, okay, who's making the decisions? Who's driving the policies? How representative are they of the societies that they propose to support? And then adding my travel bug from childhood to that, I thought, this is a global issue. Why am I just focusing on the UK? It's important. But there are areas where the challenges are even more extreme. And so that brought me full circle to say, okay, go back to Liverpool, go and do your, understand how you work in international public health space, and then take my skills out back into the global health field. So that kind of brought me full circle. And everything I do now is linked to those first questions that I had dealing with TB patients, with HIV patients, and trying to understand why they didn't have the resources they need in a society that should be able to provide it. And that question applies till today. It's still relevant to COVID and everything else that we're talking about.
Yeah, let's stay on that theme for a moment, specifically focusing on TB, because we've talked a little bit about tuberculosis on the show. I mean, obviously, you were mentioning you went from early looking at a period of HIV where things were very bad, and you've seen the transition there from a death sentence to something much more manageable nowadays. TB is one of those ones that makes me scratch my head, myself coming out of the pharma industry, because I sit here, I'm looking at your publications. You were studying outbreaks that were occurring in a college population. You were seeing what was happening with patients that weren't followed up. That you were studying BCG and sort of the spread in different, as you term, low incident country. But here we are. It is 2023, the last time I looked, and I have my little trivia on BCG, right? I mean, it was invented in 1921, and that was before penicillin existed. And a lot of those anti-tubercular drugs, they came from the 1940s and 1950s. Why? So just talk about your perspective on this one, because
Okay, where do I start?
Because
nobody cares. Because nobody cares, or at least none of the decision makers cares, which is why we have to change who those decision makers are. So, oldest disease known to man, pretty much. Maybe leprosy is a bit older, but we are still using a vaccine that is over 100 years old. Technology, I mean, nobody would license BCG for use today if it was a new vaccine. The diagnostics are still very, very limited. It's only recently that we had the recent test that's actually improved our ability to detect latent infection. But diagnostics is still really poor. Now we think, we're beginning to think about whole genome sequencing and next generation sequencing that might help with diagnosis. But TB, nobody has really invested. We're still using old drugs with terrible side effects that you have to take for months and months. And we refer to patients as non-compliant. Come on, have you seen those pills? It is your classic neglected disease, because the people who suffer from TB are on the margins of society that is usually ignored by the decision makers, the policy makers, the governments, scientists. There is no money in it. Therefore, people don't invest in the research to answer the questions. But it's 10 million cases a year. 10 million, of which 1 million will die every year. So, but the problem is nobody, of course, we shouldn't forget there's also the stigma. People don't want to talk about having TB because it's seen as a disease of poverty and dirt and neglect and all those things that nobody wants to be associated with. So we don't talk about it. We don't invest in it. There is no appetite for most of our R&D and new vaccine, new diagnostics, new treatment, new vaccine research is in the private sector. And I don't have a problem with that. Most of the research is funded, co-funded at least by taxpayers, wherever the research has been done in the world. But the decision makers about what are we going to invest in terms of R&D are not people who think about TB, because it's just not, it doesn't get the same sort of political attention, media attention, celebrity attention that some other diseases have got. Mm-hmm. The potential to find solutions, better diagnostics, better treatment, better vaccines is there. We just need to focus and drive it the way we drove for, look at how quickly we got vaccines for COVID. Granted, it wasn't from the beginning of COVID. The work had been done before, setting up the platforms, but nevertheless, it was because for some years now, we knew that the coronavirus was a likely risk to the globe. Now, if we put the same sort of attention, really, truly, we have seen some improvement in, let's not forget, since 2020, 74 million people who have HIV have been, have recovered from HIV as a consequence of the investment we've made in improving diagnostics and improving therapeutics for it. But imagine how much more we could achieve if we had the same sort of laser focus, funds, advocacy for TB as we have for every other thing out there that is sexy, and address the issues around inequity. Because we talk about, HIV is now a disease that you live with rather than die from, but that's still not the case for everywhere across the globe. And it was more than nearly 2 decades after people were living with HIV in the West, before opportunities to have ARV and to live with HIV in what is traditionally described as the global South became possible. Because there was that perception by, again, the unrepresentative decision makers that, Africans won't be able to comply with antiretroviral therapies, so we're not going to give it to them. So we've got to I keep coming back. The bottom line for whatever neglected disease is, who's making these decisions? How representative are they? Do they actually understand the perspective of where the burden of disease is? Mm-hmm. So we've got to not just invest in, but we've got to change the makeup of the people who make decisions for global health. Mm-hmm. And it's the people, it's the institutions, it's the policies, and it's not just the scientists. It's those who decide where the money goes.
Right. Absolutely. Yeah. So when you arrive at Public Health England, this is really where sort of the theme in sort of your dossier of preparedness and thinking about what's coming and the need to strengthen national public health agencies. You did studies on sort of actually various countries. Look at Nigeria, to Pakistan, to Ethiopia, studying sort of what are the challenges for these different types of agencies in terms of preparedness. I also thought it was kind of interesting. I love, once again, going through PubMed databases of our guests, but the first paper you published actually at the time was once I had to look this one up. You studying something called Q fever across England and Wales, which is a zoonotic bacterial disease, Coxiella burnetii, found in cattle. I'd love to hear just a little bit of that story, sort of when that landed on your desk, and say, "Hey, this is the first issue you got to deal with, Q fever." Maybe I didn't know, I didn't know what it was. Maybe you knew what it was ahead of time at that time. Talk a little bit about that, and then, of course, sort of the focus of your time in terms of looking at the importance of strengthening these national public health institutes.
Oh, I don't actually remember what that Q fever paper was. It's a while ago now.
No, don't worry about it.
in the UK, we rename our public health institutions and play musical chairs a little bit with them, but it's still pretty much the same trend from the public health laboratory service that was set up in just after the Second World War, during the Second World War. Then we've added bits. We had the Center for Communicable Disease Surveillance added onto that, and we started to connect it to our regional and local authority public health architecture. We moved it from the NHS into the local government, back into the NHS, all that sort of thing, musical chairs. But the roles are fairly consistent. So the role I was doing for a while as consultant in communicable disease control was created out of recognition. There was a huge outbreak of, I think it was salmonella in a hospital, as it happened in the north of England in the 80s. And there was a recognition that there wasn't enough a professional, an organizational leader charged with responsibility for coordinating the response to an outbreak. And that led to the creation of the role of the consultant in communicable disease control. So that role has evolved around from just being a physician a public health physician who looks at the disease itself, to start to look at coordinating the response and prevention mechanisms. And so working in zoonosis, we developed UK has taken a One Health approach very early on, and at local authority level, below the national level, the coordination of that what is now the One Health approach, but was then predominantly described as zoonotic infections, sat with a consultant for communicable disease control. You worked with environmental health officers in the local authority. You work with animal health colleagues in the veterinary agencies, and with the food standards agency, which was a national authority, but the local authority also had their food safety officers. So you learn to work with them to first of all, the objective was always prevent as much as possible, ensuring that standards were applied, inspections and all that were done properly. But then when you had an incident and an outbreak, you pulled those experts together to coordinate the response, because it was multi-sectoral. Right. So I took on the role as the sort of leading on zoonotic coordination in the region where I was at, and from then moved into the national center and did a little bit more work. And what we did at the national level was usually identifying those zoonotic infections that were of concern, developing policies, providing guidance and training for those who were charged with responsibility for coordinating and response. So I can't remember exactly what the Q fever outbreak was that we were dealing with at the time, but I have gone completely blank. It's been a while, and there were so many outbreaks in the day. But we did get to deal with a lot of oh my God, where do we start? But one of the beauties of the coordinating mechanism we had was that if I didn't know, I knew somebody who did. We had national experts sitting at the national level. We had local experts. We had human, we had animal, we had environmental science experts. We had networks that actually involved for zoonotic infections. We did a lot of work with farming network authorities. So the National Farmers Union always had a representative who joined us in our regular zoonotic meetings, so that they became our eyes and ears about what was going on, what their concerns were. And there was that constant exchange of information. And it's that approach that we took to emergency preparedness and response in the broader sense. I mean, one of the earliest training around pandemic preparedness that I did outside the health sector was with the North Yorkshire Police. And that was actually trying to work through a scenario of, if we had an influenza pandemic, what is your role? What's going to happen? Right. And how do we all work together to coordinate this response? So it's I think the key message that I take from my whole sort of career so far is that networking, coordination, recognizing that multiple sectors bring different perspectives to the solution, but recognizing that you've all got to bring those perspectives to actually get a solution that is sustainable and effective, was my passion. And so you asked, so how did I get into public health institutions and all that? And it was recognition of, you did that better than when there was a focal point. Right. It was tasked with saying, pull that expertise together and coordinate them so that you can actually have all hands, all voices working to a common policy to achieve, either ensure you prevent whatever it is or respond when there is an incident.
Mm.
And so the UK has had the privilege of having that focal institution for a long time, from Public Health Laboratory Service to currently the UK Health Security Agency.
Mm-hmm.
And that value, the International Association of National Public Health Institutions, which has been long supported by US CDC and Emory University, recognize the value, particularly in low resource countries, of that coordination mechanism, the fact that you can optimize the impact of the resources you have when you have effective coordination. And so we took those lessons we learned from the UK, from North Yorkshire, West Yorkshire, where I work, and started to support, how do we support these national public health institutions, first of all, advocate for their creation, and then help them to build the skills to be able to coordinate the resources they have. I mean, working with, say, the Nigeria CDC, when we first started working with them, I think they had a staffing of 35. This is compared to Public Health England at the time that had a staff level of over 5,000. So 5,000 for a population of 60 million. Nigeria CDC had 35 for a population of nearly 200 million at the time. So you need to be really intentional about how you support that institution to focus its limited resource where it needs it most and where it will have the most impact. So it was never a case of, here's how we do it in England. This is very much of a, what is the goal? Taking a very strategic approach of what is the goal? What do you want to achieve? And then how do we optimize the support you have, the resources you have, and the support from across the globe to help you get that? Nigeria CDC we had the opportunity of working with them just as Dr. Chikwe Hekwazo had been made their director at the time. And he, having worked in multiple African and countries and in Europe as well, understood the value of coordination quite well. And so we moved. One of the things I feel very proud of with that project that we led at the time is that we never came with, this is what you should do. We spent time and said, what are your priorities? Help the institutions we're working with to understand what their priorities were, their gaps were, what the local architecture was, and then help to build capacity to complement what you already had. That meant that you had to oftentimes fight to say, somebody down in London, somebody in Atlanta might think this is what they need, but actually, right, we need to actually start from the ground up. So the work we did in laboratory strengthening with Nigeria CDC, for example. Now, this was just not long after Ebola. And we worked in Sierra Leone, and we saw the situation there where there were lots post-Ebola. There was lots of capacity to diagnose Ebola in Sierra Leone, but no expansion in capacity to diagnose hepatitis A, which was also a significant problem there. Sure. So we took the approach that what we need is a laboratory system that is of good quality. And you do that by doing what it can do, what it does every day, what happens regularly. So we focus, okay, we'll help you make sure that you can diagnose cholera to the best standard. Because if you've got a good quality system, then you can bring in any other new diagnostic system into that, and they will pick it up and learn. And so that was the approach we took in all those various national public health institutions we worked for. And we also recognized they needed to have the legal power to do their job. So part of our role was also supporting them to advocate to get the legislative framework so the government says, this is your job. So you have the power in an emergency to convene. Because without that, it doesn't matter how good the technical expertise you have. If you don't have the authority to convene all parties for the response, you will be playing catch up. So those are some of the, again, so because it comes back to what I said about coordination and the fact that almost every public health challenge requires a multi-sectoral response. So the better you are coordinating that response, the better your outcomes, no matter how poor your resources might be.
Excellent. Let's move to Tony Blair Institute for Global Change, because you've been involved in several major initiatives here. I think a great place to start would be the Partnership for African Vaccine Manufacturing. We had Dr. Agwell on the show from Africa CDC a couple of months ago, and he mentioned, sort of introduced this a little bit. But and again, for everyone listening and watching the show, you can go to Africa CDC and sort of see the Partnerships for African Vaccine Manufacturing Framework Report. It's about 100 pages or so, but it's quite interesting. Take us through this a bit and sort of your involvement here. I mean, I know there's a rather aggressive plan to, I think it was 60% of all manufacturing in Africa by 2040 for the continent. Talk about that. And at the same time, if you would, because very recently, and I think this feeds into sort of the One Health theme that you were just mentioning. You just published a very comprehensive paper on One Health with basically health ministry for Zambia, Ethiopia, Chad, Sudan. You had Ambassador Kengasong from PEPFAR here involved in this paper. Integrate One Health into the African vaccine manufacturing story as well, because I think sort of they go hand in hand, especially with everything we're learning about the need to be prepared with vaccines, but for what's coming.
Okay, right. So I'm going to step back a little bit. So Africa CDC was set up in 2017. The agreement to set it up was a few years earlier, but it went live in January 2017. At that time, I had just started setting up the Public Health England International Health Regulation Strengthening Program. And like I said, it's about coordination. And it was a small project. We had 16 million pounds from Department of Health international aid budget. Wasn't that much. And we could only work with so many national institutions. So having Africa CDC, we went, hey, if we work with them, we can hit a larger number of countries because they have a continental responsibility than if we just worked on national level. So I pretty much picked up the phone and called John in Kengasong and said, can I come and see you and talk about what you're doing? And you know how sometimes you just hit it off with an individual. So John has become not just a respected colleague, and he's become a friend and a confidant. And I remember very clearly, got there at the time, he barely had an office. He had a desk, he had his laptop on his desk and on his lap, and we talked about his vision. And it was very clear at the time that this was what Africa needed to optimize the impact of limited resources it had, which is actually being able to pull together, coordinate at a continental level. And I think that we can see the difference having an Africa CDC has made in the way the continent responded to the COVID pandemic. And I'll come back to that in a moment. But back to where we were in 2017 and what was the question again? I've digressed and I've forgotten. It was, yeah.
I would just take you to unpack Africa vaccine manufacturing, and then obviously the connection to One Health.
So I had worked with John over the years through the project I was leading in Public Health. I was leading Public Health England. So when the COVID-19 pandemic hit, we were supporting the project. Even though we had to return our staff back to England, we will continue to work with the countries and national public health institutions we were supporting to exchange technology and learning. So, for example, we're able to share the initial the mechanisms for diagnostics for COVID with Nigeria. We contributed to training that Africa CDC was coordinating for laboratory diagnostics for emergency preparedness and response across the continent. So in one of my numerous conversations with John at the time, and he'd say, talking about the problem of the absence of manufacturing of what are now called medical countermeasures, but I think health technology on the continent. And because COVAX had been initiated, there was all this talk about, we will have it's a global public good, resources will be shared equitably. But we recognize that for a continent of 1.4, 1.5 billion people, to have only 1% of its vaccine needs manufactured domestically didn't make sense. If you look at the map of where vaccines were manufactured and where the burden of disease were, it didn't make sense. So John convened with the President Ramaphosa, who was the champion for COVID-19 response on the continent, and other key people. They convened this conference in April and said, we've got to challenge ourselves as to why this is the case. And we're talking about vaccines here, but the same deficiency applies to therapeutics and to diagnostics. And so I had been working with PHE. We'd been, nonstop in the COVID response. And I was personally feeling a frustration with our ability to engage constructively with politicians. And this was as a public health institution in the UK, and feeling that there must be a way to be better able to communicate what the need is, so that politicians and public health experts didn't seem to be on different planets, which, if you listen to the news at the time, that seemed to be the case, and it wasn't just in England. And I had worked with Tony Blair Institute years back when they were supporting Nigeria CDC in its early days. So serendipitously, they said, well, if you're thinking of taking a break, why don't you come and work with us? And I thought, this is a good opportunity, because they work at the center of government. Right. Their role is working with the leadership of countries to improve the lives of their population. Use strategy, policy, and delivery, and then applying technological solutions. I thought, well, come and work with them, and that would be a good way to start to fill this knowledge gap I felt I had. And so I think within my first week or two of working with TBI, John had a meeting with Tony Blair and asked him to release my time to support establishing this partnership for Africa vaccine manufacturing. So that's how I got into it. And its goal, like you said, to move from 1% to 60% of our vaccine needs manufactured on the continent by 2040. Very ambitious. Of course it's ambitious. It should be ambitious.
Sure.
Now, it's not the first time we've talked about vaccine manufacturing on the continent, but what we did was take a strategic and a systemic approach to it, to say, how do we create the enabling environment that will allow this industry to grow? And the value of having a coordinating mechanism in PAVM, so that we're all working to the same goals. And that was from which vaccines, what technological platforms, what area of the value chain, how do we ensure that we've got the right R&D to underpin this, the right talent development, workforce development? How do we ensure that we might address the legal and complex issues of IP and technological transfer? So, I would say first and foremost, and most importantly, the regulatory framework. So when we started this work, we had only two national regulatory authorities on the continent who met the WHO maturity level 3, which is the minimum level you need to be able to regulate the production of vaccines. Now we're at 7, and before the end of this year, we will reach 11 of those. That's rapid progress.
Absolutely.
We looked at how do we ensure that the money is available to support the starting up, but most importantly as well, we talk about vaccination and Africa, 1.45 billion people, one of the highest child fertility rates. So we have a pool of there's a demand, or there's a potential demand for vaccines going forward on the continent, which is great. But if you're a manufacturer, you need certainty of how you get your product into arms. Right. That's what you need in order to commit the investment in actually manufacturing that product. So one of the things that we've put a lot of effort into is how do we create these mechanisms to demand, to shape the market so it's attractive to manufacturers. We have the advantage being based in the Africa Union. We could link up with the now created Africa Medicines Agency, can link up with the Africa Free Continental Trade Area agreement, which is around ensuring that there are trade policies that allow for effective movement of goods within the continent, all critical for vaccine manufacturing. And most importantly, it's around coordinating. So that 1.4 billion population looks good for continent, but not if all 55 countries start trying to produce the same thing. Then there are very few countries that have enough demand within their own borders to sustain new vaccine manufacturing. So we were always looking at least a continental population, but more important, eventually to be part of the global solution. And then, of course, the lessons of COVID and COVAX and the delay in delivering, the fact that even though we got the vaccines very quickly, it took a lot longer to scale up the manufacturing capacity,
Right.
is a recognition that part of your emergency preparedness is having a diversified health technological or health countermeasures manufacturing base. So that you don't put all your, so COVAX was entirely reliant on what was coming out of India to serve most of the world. India had the Delta variant, and they had to, you can't blame them for saying, we're going to start to supply our population first before we start giving to COVAX. Yeah. So Africa, which had no vaccine manufacturing capacity of any size, was at the end of the line. So it is part of emergency preparedness and resilience to have diversified manufacturing across the globe, and Africa has to be part of that solution. And I'm really pleased that Gavi and others have now come to accept that and are working to ensure that their marketing strategies consider new manufacturers and support the emergence of new manufacturers on the continent. So we're making progress. Senegal is our shiny, I wouldn't say shiny, because Amadou Sall, who is the CEO of the IPD, Institut Pasteur Dakar, has worked really hard to build. They had vaccine manufacturing capacity for yellow fever in the past, so they built that up, and to diversify and start to build on not just traditional vaccine manufacturing technology, but looking at how they might also adopt mRNA technology to start producing more vaccines. We still have the issue of what happened in South Africa with Aspen, where they got all the efforts to produce COVID vaccine, but then no markets. And that's why we can't just say manufacture. While you're talking about creating the infrastructure and the processes for manufacturing, you also need to be talking about, and how do you get that product to a market? That's so important. So that's one of the things I learned in TBI is I can now talk about market shaping and demand creation and demand management, which was not something we do talk about very much in public health generally. So I've learned a lot from there.
Absolutely. And then just, alongside that, because obviously, making amazing strides per, this manufacturing plus, manufacturing plus program, you also were involved in creating something known as the Kofi Annan Leadership and Global Health Program. Obviously, with all this infrastructure and development that's going on, you need that next generation of people that are not just going to be working in these factories and companies, but the next generation of public health leaders. Simultaneously, alongside that, you wrote this very interesting article a couple of months ago with Dr. Giapong from Ghana, entitled "Africa Needs More Women Leaders in Public Health." And if I could just read a short paragraph here. Studies have shown that women leaders are more likely than men to address the needs of the community and to direct funding towards education, health, and nutrition, as well as support critical interventions such as immunization, antenatal care, and health facilities. In short, when women are included in decision-making, it leads to better health outcomes for everyone. I love that. Talk a little bit about the Kofi Annan project, but also this article.
Right. Now, the Kofi Annan Fellowship Program was another of John Kengasong's ideas, but, which found its time in. Too often, when we talk about underrepresentation of women, of Africans, of various geographical or minorities groups, there's always says, but there are no people there, which isn't actually true. But what the Kofi Annan Leadership Program is to say, okay, who are those people who are already on their leadership journey, and how do we give them the opportunity for profile, for visibility, to build up support networks so that they are ready for those global leadership roles when they arrive. And we had the privilege of being supported in this ambition by a funder which is not to be named, to say, okay, start doing this. What do we need? So first year, the aim was 20 fellows gender balanced, and the funder was very specific about gender balance, and we thought if we need to, we might have to weight the scoring to ensure that they're women. And I remember very clearly sitting with the steering committee saying, we are not going to need to weight the currents because I know the women are there. So first call, we had about just over 1,000 applicants, from which we chose our 20 without any weighting. We had 10 men and 10 women. Second time, we had just over 3,000 applicants to choose 20. We had 11 women and 9 men, and we're just in the process of recruiting for the third cohort. But for me, what we've done is, first of all, is introduce them to the global health architecture, the system that they need to be preparing to lead, making sure that they understand how it works, what its challenges and limitations are, and creating a network, a support network. Because one of the things I learned from my own personal leadership journey is that being the only woman, Black, whatever underrepresented group you are, is a very lonely role. It's very draining. And having a constituency and a network who understand your experience, who can back you up, actually makes you more likely to stay and to be successful. So part of I think the intangible benefit of this network is that there are cohorts of Kofi Annan fellows who can call on each other, who can support each other, can encourage each other, who can open doors for each other. And I feel particularly proud to be part of that, because it's been a way of learning, sharing my own journey. I keep telling people I never had a mentor till fairly recently. And when I discovered it, I went, how come nobody told me about this? So because the value of having somebody who is there for you to sound off on, who understands what your challenge, your journey, who hasn't been there, who could open doors. Or I say to one of my mentees, I said that a sponsor might get you into a room, a mentor gives you the skills to stay there.
Right.
And that is so important. So I'm really proud of the Kofi Annan Leadership Program. It's like I said, we're just about to recruit our third cohort, but we are looking to a space where you cannot make an argument to say, oh, we didn't have any women or Black people or Africans in for these roles because we don't know where they are. Because they will be there, they are there, but we would have given them the platform and the visibility, so that argument becomes moot. Right. That's really, really part of the excitement of that program. And then to the women. So first of all, I make no apologies by being a very, very strong advocate for women. One, I am one. I was raised by one. And we know what that quote you read is based on statistics. Women are the decision makers in the family for health. On the decision, it is in every culture, in every society, women are predominantly the decision makers about how the family's resources are used for health, for investment. They are often the care providers. The report from Women in Global Health showed that, we know that 75% of the health workforce are women, but only 25% at leadership. If you start to look at the unpaid care workforce, that moves up to 95%. And it's a consistent pattern wherever you are in the world. So if we value health, which if anybody had any doubts before the pandemic would have put paid to that, we know how important health is for economic development, for everything else that we as a society feel we want to do. You have to have health first and foremost. Then how can you have a system where the decision makers, the major providers, are not involved in establishing the policy and implementing the strategies for the health solutions that we need? It's like going into a conflict and leaving half your army behind. Not just half your army, the army that does it every day. So there is no, it's not rocket science. We need to improve the representation of women in the decision-making spaces at every tier, from the community to global architecture. And we also need to make sure that, because we have to talk about intersectionality here, we also need to make sure that all the other marginalized groups the indigenous communities, racialized minorities, disabled, other dimensions of description, LGBTQ plus, all those things. If we don't have the full spectrum of society involved in making the decisions for health, we are always going to have poorer outcomes because we will miss something. So take, for example, in the COVID response, the vast majority of the COVID task forces were led by men because there's this cultural belief that, in an emergency, you get the men out. Let's not go there. But they made decisions, and because there were not enough women involved in the consultation and the deliberation about those decisions, we missed the fact that if you do lockdowns without consideration of childcare, women in the workforce are the ones who, even despite society's progress and everything, they still carry the burden of care for children, for elderly relatives. So they were disproportionately impacted by lockdowns. They're more likely to lose their jobs, they're more likely to lose income and not be able to return at the end. And of course, we now talk about the Great Resignation and the burden of stress that the global health workforce bore during the pandemic. And a higher proportion of that is women. Now, we have to have women not just involved in the decisions we should have made in the first place, but in the recovery. The lessons learned from pandemic, you have got to have the voices of the women and the other marginalized groups to say, how was it for us? And these are the things that we need to do differently, because I don't believe in going back to normal. We've got to learn. Although it's unfortunate, everybody is trying to sort of pretend the pandemic never happened and go back to reality. And if we do that, we will be having this conversation again and again and again, because another pandemic will happen.
Right.
So women have got to be there, front and center.
Absolutely.
Mm-hmm.
You are taking on, I mentioned in your bio, and I'm not sure if you've begun, or I know that I read somewhere it says next month. Okay. CEO, Africa Public Health Foundation. In addition to everything else you're involved in, say if you, because I mean, the organization, and we'll put a link to it as well in the bio of the show, but obviously all the themes that we talked about today, accelerating diagnostics, regional collaborations, vaccine equity, all the things that you're very passionate about. Talk about sort of what's next on sort of this, are you moving to Africa CDC? Because I think, is it based at Africa CDC or no? Okay. Take us into this.
It's based in Kenya. In Nairobi. Okay. And the Africa Public Health Foundation, so the WHO has WHO Foundation, US CDC have CDC Foundation. Africa Public Health Foundation was set up to help fundraise and develop partnerships and stakeholders to support Africa CDC's mandate. Now, Africa CDC has a very clear mission about improving the global health, the public health architecture and coordination of the global health architecture to improve the health outcomes for the African population. So there's a multiplicity of things that Africa CDC is responsible for leading on behalf of the continent, on behalf of the African Union. Now, it can't do all of that by itself.
Right.
And also it needs funds to do it. So part of what the Africa Public Health Foundation's mission is to help to fundraise and to manage some of that funds to support Africa CDC's goals. So when it was set up just before the pandemic. But when it was set up, the Africa CDC was also still under the AU Commission as a department under the Health and Humanitarian Department. It has now been elevated to an autonomous technical agency for African Union, which is great because it gives it much more flexibility to work as an organization that has an emergency responsibility. Prior to that, the architecture for it to make decisions about funding, about recruitment, all had to go through the AU Commission, which is not a rapid responder. So the autonomy gives it that flexibility to move, but it still needs to generate funds. Now, one of the biggest challenges we have on the African continent is domestic investment in health. At too many countries, in too many tiers, investment in health is minimal, and it's too often is dependent on donors. Now, we need to change that narrative. We need to drive our governments, and this is where one of my other particular passions is about. We need to get the civil society and our citizens to recognize and own that health is a right, and therefore their governments have a duty to enable them to have access to good health and health systems, so that they can advocate for their governments to actually invest more in the health system. But in the meantime, how do we leverage global partnerships, donors, whether they're national donors, local donors, international donors, leverage them to optimize the impact of international aid, philanthropy, and in some cases, private sector investment. And what the foundation brings is the capacity to coordinate some of that, to align donors' interests with the strategic vision of Africa CDC, to try and limit some of these parallel and vertical programs where we have multiple funders funding single track programs, which isn't efficient. It is not an efficient use of the resources that we have, but it also means, and a respected colleague talked about autonomy of goals, and the autonomy of goals means that you have an organization has the autonomy to decide what its priorities are, and that is dependent on being able to control the funds that come to you. Now, so Africa CDC having a strategic vision saying this is what we're supposed to do, if it then can't manage the funds to make sure that they're channeled towards those priorities, it doesn't really have autonomy, because it'll have what we see over and over again at different tiers, where the priorities are driven by who brings the money. So part of the vision for the foundation is to help to coordinate some of that funding, so that there is a common vision that the funding steers through, and providing efficiency to complement what Africa CDC and the African Union can do in terms of managing that funding. So going to APHF for me, again, is a slightly sideways move, but it builds on the journey that I've been on, which is I understand the public health system, I understand the public health challenges, and now bringing that to bear in the conversation with partners and funding and fundraising to say, this is how we channel the resources to optimize the impact on the continent. I'm really looking forward to that challenge.
Yeah, that's definitely another exciting piece of this story. So I, wishing you the best with this part of the journey as well. A couple weeks ago, you were in Kigali, Rwanda for the Africa Health Agenda International Conference, talking about these themes. What else is coming up for 2023 as far as your public-facing initiatives? Other conferences you're going to be attending, presentations you're going to be giving where we could listen to you, watch you, potentially meet you? Anything else for 2023 that's hot beyond everything else that you're doing? Please take the floor.
Oh, okay. So next week, and sometime next week, next few days, as you know, India has the presidency of the G20 this year, and they've put domestic manufacturing and a diversified manufacturing of health medical countermeasures as one of their priorities that they want to push for, which is really wonderful, because India has been the pharmaceutical kitchen for the world. They understand what it takes to actually diversify and expand your pharmaceutical manufacturing base. So that for them to lead the charge for local, low and middle income countries to be part of this manufacturing solution is really welcome. And then I will be attending one of the side events there to talk about specifically how do we expand the base of manufacturing of diagnostics. And that, again, links into sort of what we talked about at the beginning around TB, for example. But the challenge we had with COVID wasn't just the access to the vaccines. For a very long time, we didn't even have access to tests. So you couldn't tell what the true burden of disease was in a lot of low-income countries. So that's I'm going to be involved in a panel discussion that FIND are coordinating in Goa in a few days' time. I mean, this is WHO's 75th year. So the World Health Assembly is their 75th birthday is this weekend, actually, on the 7th. And there's the whole conversations around the pandemic treaty, the review of IHR, and there's so many conversations happening around how do we improve the functionality of the global health system, which I intend to be part of some of that conversation and to contribute to some of those conversations in different spaces and guises. But my passion remains first and foremost, how do we improve representation of Africa in these conversations, but also how do we as Africans get better at looking for our own solutions? So towards the end of November, we will have what will be the third International Conference for Public Health in Africa, which Africa CDC convenes. It's going to be in Zambia this time, I think the last week of November. So we had the second one, which was the first face-to-face one last December, and the first one was done online the year before that. And one of the chairs of the steering committee described the last conference there as a homecoming. And I think that was so appropriate because it did draw in Africans who were focused on saying, how do we actually co-create and lead the solutions for the problems that we face here? So I've been on the scientific committee for that since it was established, and we went from having a side event for women in the first conference to having a whole plenary for women in the second conference, and my goal is to have a whole day to focus on women and their role in the health systems for next year. So watch that space. We're just beginning to look at the agenda for that conference this year. But there's always there are loads of things. My passion is how do we optimize the opportunity from the pandemic to learn the lessons before people walk away. We have a very macabre saying in communicable disease control where we say never let a good outbreak go to waste, because you get a focus of attention then that you don't have in peacetime. So we need to continue to use that focus now to make the changes that need to be in place. Otherwise, next pandemic, because there will be another one, we'll be talking about the same problems again, and that would be a failure on our
part. It's going to be a busy 2023 for you, but I mean, it's an amazing portfolio. I've so enjoyed listening to you talk about it, and really wishing you the best with all of this, because it's such a critical intersection that you're working in. So again, for everybody that is going to be listening to this particular episode of our show across the various podcast networks or watching on our YouTube channel, again, you've been listening to Dr. Ebere Okereke, Senior Advisor in Health, Tony Blair Institute for Global Change, Honorary Senior Public Health Advisor at Africa CDC, Associate Fellow at Chatham House, and the incoming Chief Executive Officer of the Africa Public Health Foundation. Dr. Okariki, I want to again thank you for taking the time out of your schedule to come talk to us and educate us on these themes for a little while. Obviously, thank you for everything you're doing for so many people out there. And as we like to say on our show, thanks for helping to make a better tomorrow. Really, really great story.
Thank you so much. Thanks for having me. And I'm just the voice for the hundreds and thousands of people who I work with and who have this same commitment to improving the health of people on the African continent, but on the globe as well. So it's an honor to be on your program. I've really enjoyed talking to you. Thank you.
Great having you.